move to our final talk of this morning, and I'm pleased that Dr. Scott Norris can be here to speak with us. Scott is in the neurology department at the Washington University School of Medicine and has been doing a lot of research thinking about deep brain stimulation. So he's going to give a little bit more of a clinical perspective on controlling neural circuits, some of the potential applications in that area. So,
thank you so much, Ian. Thank you for the organizers for allowing me to speak today. I feel a little bit bad because I'm the only thing standing between you and lunch, and I also don't have any formula in my slides today. So I'm going to give more of a clinical perspective today on deep brain stimulation surgery. I've received honorarium from Medtronic as far as disclosures, and I received various funding sources through the NIH, and then also locally through the American Parkinson Disease Association for research associated with DBS. I think first and foremost, deep brain stimulation surgery for us, simple, right? It's not rocket science, it's neurosurgery. And this is a slide that represents what we do here. This is, a wire that we place deep inside the brain. It's placed in deep subcortical structures. And then that's achieved by drilling a very small hole in the skull. Falling through that hole, we have a wire that connects to a device in the chest. This device in the chest allows us to communicate with the device. This represents the electrode here, the span of which from here to here is between 7.5 to 10 millimeters. So it's a very small structure, and we're targeting very small structures in the brain. The stimulation here is a high-frequency stimulation. It's a constant stimulation, at least in the current state. I think that's something that we can talk about as far as potential advances. Patients with this device come to me. They come periodically, once a month, once every 6 months for periodic tune-ups, because these are for diseases that continue to progress and require adjustments as an open-loop system currently. So I've got a couple examples here of, and if we don't mind stopping. The thing I want to make as far as a point in this slide, as far as the history, DBS is an empiric therapy. We, as clinicians, make mistakes and make important discoveries, and I'll explain that here. People played with electricity for a long time. In 40 AD, I think they were applying electric eels to the scalp to treat headaches. It wasn't until the 1800s that we really started stimulating the cortex, but the 1940s advent of the stereotactic apparatus really allowed us to dive deep into the brain and get a precise, accurate localization. Initially to allow surgeons to create lesions in areas of the brain that cause problems. The 1952, this is the mistake I was talking about. So there was a surgeon who was going in to treat a syndrome Cooper, and he actually disrupted the vascular supply to the globus pallidus internus, one of the targets that we now treat with DBS. And lo and behold, the patient in which this vascular supply was disrupted, a stroke was created, and the symptoms of Parkinsonism were better. So this created a whole literature on pallidotomy, so again, scooping out this section of the brain and creating benefit for these patients. During this time, surgeons were able to macrostimulate. They were able to send electricity to the brain. The reason for this at this time was actually to locate localized regions that were close to the GPI that might cause side effects. The internal capsule, which carries information to the motor cortex through the spinal cord. And so by stimulating areas in the internal capsule, it can cause abnormal movements. And so you obviously don't want to disrupt, scoop out that portion of the brain, but rather adjust your brain. But with that macrostimulation, they noticed again that there was benefit of Parkinsonism. So this was really the first case series of DBS. Then along came a medication that's very effective for treating Parkinson disease. Research really kind of died down at that point. Not until 1987 in France, Benabid described the first series of patients with the modern DBS devices that we use now. And it was not FDA approved until a few years later, actually 1997. One thing that's important, so again, getting to that empiric realm, it wasn't until the 1990s that we really created and started utilizing animal models to study these circuits. And so MPTP, a toxin that we can inject or apply to the brain and create lesions very similar to Parkinsonism and Parkinson disease. Indications of deep brain stimulation surgery, this is important because we treat very different diseases with DBS. And so on the top, I have the FDA-approved diseases, essential tremor, again, postural tremor. When people are using their hands, it's much worse. Parkinson disease, arrest tremor. When they use their hands, that tremor actually diminishes. Essential tremor and dystonia. So dystonia is a neurologic disorder that causes abnormal posture, tightness of muscles, can be very painful and obviously very disabling. Essential tremor and dystonia are hyperkinetic movement disorders. They cause excessive movements. Parkinson disease is interesting, and particularly in the realm of DBS, because it's not only a hyperkinetic movement disorder where we have increased tremor, but you also have the bradykinesia, the slowing of movements, the stiffness. And thinking about this in a network disorder and at a single point of stimulation is an interesting concept, and I'll get to that a little bit. And then obsessive compulsive disorder, a very different disorder, a psychiatric disorder where very severe cases respond to DBS. And there's this whole slew of literature now, phase 1, phase 2 trials on various disease states where DBS has shown some promise. I've already mentioned most of this. I'm going to focus on this talk primarily on Parkinson's disease. This is probably actually, in fact, a mistake just based on what I said, because Parkinson's disease is the most complex of these diseases. It has hyperkinetic components. It has hypokinetic components. It also has neurodegenerative processes that affect the cortex outside of the neural circuit that we're studying. So this adds layers of complexity in how we interpret this on a clinical realm and how we measure the response of DBS. But as a whole, Parkinson's disease is defined by the motor features. So I've already mentioned these: the rest tremor, the rigidity, the bradykinesia, posture instability. It's caused, at least these motor symptoms result from a reduction in dopamine in a particular region of the brain, the substantia nigra, that projects to these areas that I'm talking about, the basal ganglia and the striatum. We can replace that dopamine and patients get markedly better. The problem over time is that medication lasts less time. The medication can last 2 or 3 hours in some cases, and so these patients are required to take this medication constantly. They ride a roller coaster every day, all day, because as that medication wears off, as it kicks in, they have benefit and then they lose that. Dopamine, levodopa, also contributes to many side effects. So that's where deep brain stimulation surgery and PD really comes to play. When I choose patients for DBS, I'm looking at that. I want to make sure that A, they respond to the dopamine, because that proves that they have Parkinson's disease, and it's going to respond to DBS. But B, they have limiting side effects, and this is brain surgery. It comes with risks. We don't want to place somebody at risk if not necessary. Again, important in Parkinson's disease is that despite focusing on the motor features for this talk, there are a whole slew of other features. There's cognitive decline. Dementia occurs in 80% of Parkinson's patients at much later phases. There's depression, there's anxiety, constipation. None of these respond to deep brain stimulation surgery. It's really the motor symptoms. The other thing about deep brain stimulation surgery that's important is it's not a cure. It doesn't slow the progression of the disease. We're treating symptomatically. So the best we can do that is important. This slide represents the process. When we place some DBS in someone, we have them come into the operating room. We place a frame of reference on their skull. This is just a frame that allows us to do that. We take a picture with an MRI. Again, these are the external references here, so it allows us to create a coordinate system for the neurosurgeons to direct the stimulation. This is the most important thing, I think, for this group here, is that I'm in the neurologist, I'm in the OR, and I'm able to actually record neurons in the brain. I can record with my microelectrode, and I can also record local field potential. And so our strategy is to place the electrode, the microelectrode, or the local field potential macroelectrode about 1 centimeter above the target. We drive it through these various structures. So for the STN, the subthalamus nucleus, a target for Parkinson's disease, we start in the thalamus. It has a very characteristic neuronal signal. I can hear that on the audio, and I can also see that on my screen. We pass through structures that are kind of a white matter track that divide these areas. We lose our signal, and then once we insert our target, we have a very characteristic pattern. We're able to map the top, the bottom, and then we calculate the middle, and we place our electrode right there and get the optimal stimulation. So that's important. And then we're able to visualize what we've done post-operatively and confirm that we're in the ballpark. Localizing electrodes actually is probably kind of one of these. This is something that's involved. I'm involved in a lot of research in. It's an important component because we're talking about a very small anatomy here. The subthalamic nucleus is only roughly 6 millimeters by 9 millimeters, and that's kind of a larger STN. We can do this in various ways, and in fact, that's why we, at academic institutions such as ourselves, perform microelectrode recording. Because when we perform DBS, after we obtain the preoperative imaging that I was showing you, we place a wire in someone's brain. When we do that, the brain deflates. There's CSF, fluids that surround the base seep out. Air enters the brain. This is an extreme situation, but you can see this air, and then over time, that air resolves and the electrode actually shifts. determining how that electrode shifts in relation to the brain and the anatomy that we're targeting is very difficult. It's difficult because of the limitations in the technology we have. CT, X-rays allow us to see the contact tip very well. MRI allows us to see the anatomy very well. Unfortunately, CT does not allow us to see the anatomy. MRI does not allow us to see the contact tip very well. Some people do that, but we're going to argue that there's a significant amount of unpredictable artifact that occurs when you place metal into an MRI. And so precisely determining where that contact is very challenging. And then furthermore, depending on how the head is positioned in the scanner can also influence where that electrode appears in relation to skull and the anatomy. Gravitation alone pulls on the jello brain and can shift that electrode. So in thinking about circuits and how we're interpreting the response of our stimulation, we really need to think about where we're accurately how we're accurately determining where these electrodes are. After the device is placed and when they come to our clinic, we turn on the device, we create a monopolar survey, so we have 4 contacts, and essentially we increase the voltage and determine a therapeutic window, right? So we're determining at what threshold do we get motor response, what threshold does the tremor get better, the slowness moving, the stiffness, and then how far can we push that until they get a side effect from stimulation. The side effects from stimulation are because we're more than likely tickling a part of the brain that's very near to the STN or the GPI in these cases. We have a few parameters to manipulate. We have voltage, we have frequency, and we have pulse width. It is a square wave balanced cathodic pulse that we're putting in here. Again, it is a constant stimulation. So there's not, at this point in time, we're not adjusting based on feedback and those types of things. I've placed this here. All this really is so this is a map of the brain. Looking, slicing through the head like this, looking at it from this perspective. The concept I want to display here is that really, from a motor benefit, this target is forgiving. No matter where we stimulate within this target, there seems to be a significant motor benefit. So the UPRS-3 is a scale that we use clinically to objectively, probably some subjective component to that, but measure response to DBS. And wherever we are in this target, that improves. However, there also seem to be localized effects, and I think this also is important in thinking about where are these circuits changing, breaking down, and how do they affect that. And so bradykinesia seems to be in a more superior aspect of STN, the tremor seems to be in more inferior aspect, and then side effects we can see by stimulating various areas. Working memory can be affected, anxiety can result from stimulation. The important component for me as a clinician, but also thinking about this and these networks, is that DBS failures result from suboptimal lead placement, and that's been demonstrated previously and is an important concept. So obviously you guys are involved, and girls are involved in the circuits here. Thinking about this, I don't expect everyone to walk away remembering this if you haven't already. But the idea is that this is the motor cortex, this is the basal ganglia, which is an intricate network in and of itself. This is the relay, the thalamus, and then over here is the cerebellum, which we've started to demonstrate has a larger role in these diseases. Grossly, the cerebellar thalamo network seems to be most involved in tremor and stimulating the output nucleus of the cerebellum, or the output relay in the thalamus really seems to benefit tremor, and that's our target. This is our target for essential tremor. But thinking about Parkinson disease, and I guess I should say that this also, patients with Parkinson disease who have a rest tremor, stimulation of this also benefits that rest tremor as well. But more importantly in Parkinson disease is the network over here, the cortex stimulating the basal ganglia. The basal ganglia has a single output. So this here, the subthalamic nucleus, this here, the GPI, or the globus pallidus, or Pars interna, are stimulation sites that we target with DBS. Those are the output nuclei, essentially, of the basal ganglia. Those targets actually integrate multiple signals that are processed through the basal ganglia. There's a hyperdirect pathway that comes directly from the cortex to the STN. There's an indirect pathway that comes through the GPI, and then the STN, then GPI. And there's a direct pathway. If you send electricity into the motor cortex, you can measure a triphasic response in the globus pallidus, pars interna. You can measure a diphasic response in the STN. And that response is actually affected when we stimulate with DBS. So thinking about the integration of those signals is important from a mechanistic standpoint. This here is just the anatomy demonstrated, kind of indicating that this basal ganglia structure is deep subcortical, and hence the term deep brain stimulation. So thinking about mechanisms of DBS, we always want to understand better what we're doing with this, even though we have a kind of a serendipitous empiric formula that works for us as clinicians. Does the effect, the initial hypothesis was that the effect is equal to a lesion. We scooped out a portion of the brain. We have the same effect when we send in a wire and pulse electricity through that. Now, does that inhibition of signal result from depolarization, or does it occur as a result of synaptic activation? There's some nifty experiments here. All this is showing is there's a raw signal here, there's a raster here, and there's a histogram here. This actually is zoomed in, so you have 1, 2, 3, 4, 5 pulses. With deep brain stimulation surgery, you have an inhibition of signal. That's represented here where we zoom out a little bit. And so we do inhibit signal from the GPI when we stimulate with DBS. But it seems not to be just depolarization. We're not depolarizing the neurons. We are also activating the GABA, the presynaptic signaling here that occurs at a neurotransmitter level. And so this is shown here where gabazine, a GABA antagonist, is applied. When that antagonist is applied, despite the stimulation, there's actually firing within that nucleus. Now, that was the initial hypothesis. We've learned a lot more since then. Cameron McIntyre, Butts and Grill have done a lot with this in modeling these areas of the brain and demonstrated that multiple actions differ with regard to the distance, spatial orientation of these electrodes. That gets a little bit more complex because not only are there are different levels of stimulation resulting in different actions. And so suprathreshold results in axonal spikes. So the axons themselves pulse at the high rate, the 130 or 185 hertz. Subthreshold results in spontaneous action potential processing. And so now things get a lot more complex because not only are we sending signals locally and inhibiting neurons, but we're also sending signals both efferently up the chain, but backwards antrodromically because we have those presynaptic axons that we're stimulating in the local field of effect. So, the precise mechanism of DBS is very complex at this micro level, and so this plot here I'm demonstrating really to suggest the locality. This really is that 5 millimeter span here, and when we expand our current, we start hitting a lot of different pathways that are crossing paths here, and thinking about those axons that pass through there is important in further developing our circuits going forward and the mechanisms. Does that matter what we're doing locally? Maybe not. We think about downstream effects, and clearly there are downstream effects. This is just a PET image here. When we turn on DBS and compare that to the off state, we see blood flow responses in the thalamus. We see blood flow responses in the premotor cortex. Clearly this is a network effect, and the propagation, the disruption of these abnormal basal ganglia signals are changing these downstream effects. This is supported clinically. Again, comparing DBS to ablation. These are important components. Both ablation and DBS eliminate the signs, the symptoms of Parkinson's disease, but they don't completely ablate or eliminate the known procedural learning and motor control that the basal ganglia as a whole is involved in. So we're not completely disrupting or eliminating the normal basal ganglia signals that go through there. And so new mechanistic theories really focus on the filtering of information as opposed to the blockade that we initially started with. And again, thinking about on a systems level, maybe perhaps we're stabilizing equilibrium in this network. Evidence for this is in the local field potentials. I think I'm preaching to the choir here. I think most folks here know that the basal ganglia itself, there's independently firing neighbors in the normal state. In Parkinson disease, those neurons actually start becoming more synchronized, and that's where we see these LFPs. We see this in the beta range, and I think I have another slide that mentions that. In normal movement, we already heard about the desynchronization of the beta rhythm. That precedes movement. At the time of movement, we have an alpha burst, and then following that movement, we have the beta synchronization. So thinking about that network that I presented before with the GPI output into the thalamus, we think about that as a brake, and that may, releasing the brake may allow us, to relieve at least the bradykinesia and perhaps the rigidity component of Parkinson's disease. And this kind of reiterates the abnormal LFPs in Parkinson's disease. We have increased beta oscillations throughout this entire system within the basal ganglia. but also in the motor cortex. And this, at least clinically, as far as we can tell, is most really closely related to bradykinesia. It's not completely linked to the tremor and the other symptoms, the postural instability of those components. Further supporting this notion that LFPs, or at least play a role in this, DBS, high stimulation frequency, decreases the beta synchronization in the motor cortex. Stimulation in that beta range at the SDN, at the GPI, exacerbates the motor symptoms. So taking this one step further, thinking about the phase amplitude coupling, there's clear demonstration that there's phase amplitude occurring, coupling that occurs in these systems. There's increased beta gamma coupling in the basal ganglia cortical loop that we've discussed. Specifically, the gamma power peaks precede the beta oscillations. This probably contributes to a feedback loop, and so disrupting this feedback loop and creating an improved equilibrium likely improves this. And so the hypothesis outlined specifically here, excess motor cortex beta synchrony manifests as bradykinesia rigidity that results from pathologic beta oscillations that are passed through this loop, and by intervening in that, the filtering the basal ganglia output, we can improve the symptoms. And so in Parkinson disease, in deep brain stimulation surgery, we see that, right? So this is kind of the sentinel paper in phase amplitude coupling, where on the left we have before deep brain stimulation surgery. This is the beta range, so this is the frequency from 0 to roughly 50 hertz. And on this axis here is the gamma range. Unfortunately, this got cut off, but this is 250 hertz, so 0 to 250 hertz. We see a very nice coupling in the disease state prior to deep brain stimulation surgery, or deep brain stimulation, turning on the device. When we turn on the device, we lose that coupling in the gamma range, and then again that returns once that DBS device is turned off. So thinking about DBS and eliminating the cortically evoked triphasic response that I talked about, how does this affect the circuit at the local level? Maybe it doesn't matter. DBS disrupts those beta oscillations, alters the power, and creates a more regular firing pattern. The point I want to make, and I've already made this, but I want to reiterate, is that this is in the context of a single symptom of Parkinson's disease, bradykinesia. And so in this small system that also stimulating GPI, STN, benefits tremor. Where is that signal? How do we represent that? How do we determine that? Are important questions. Taking this, how do we take this and develop this into important ways to improve therapy in the future? I think there's a few conceptual notions that we need to take away from this, and I think these have already been mentioned, and this is obviously something that everyone in this room is focused on in some way, but optimizing the detection and extraction of these control signals, right? We can't do anything until we've done that and optimize these signals. And these very tiny regions of the brain that have numerous pathways crossing and moving, how do we best determine what signal is relevant to alter? We need to continue to improve our understanding of pathophysiology. These recordings, what we're doing with neural processing and understanding these signals, local field potentials, the coupling of devices is very important in understanding the pathophysiology of these diseases. How can we create reliable biomarkers of tremor? How can we create reliable biomarkers of bradykinesia, rigidity? And then furthermore, how do we correlate these with the clinical signs in such a complex disease? Again, backtracking, perhaps essential tremor, perhaps dystonia are simpler models because they don't have the other components in the disease that may affect our correlation of these signs and symptoms. Comparison across diseases, longitudinal evaluation. Parkinson's disease isn't static and DBS isn't static. We're making adjustments all the time, so thinking about that is important. And then are there biological disease changes occurring at the local level or systemically that are occurring as a result of stimulation? There are some early preliminary animal models that suggest that DBS may be neuroprotective. I don't think that's true, but these are things that we need to continue to explore. So are there growth factors being released that are helping stimulate dopamine or those types of things? Not so much on the systems level, but certainly could play into neuronal signaling. And then I think folks have already mentioned, our early speaker mentioned the technical limitations. There's cost associated with all this, cost to us as researchers, cost to the patients themselves, and we need to recognize that. We need to recognize that there are limitations in our technology with current battery stimulation. We certainly don't want patients walking around with devices and wires and antennas and those types of things that are affecting their activities of daily living. So people are working on improving technology, and those are important concepts, but we need to recall that and remember that when we're treating patients. Future directions: improving deep brain stimulation surgery, reduce side effects, right? As a clinician, I want to reduce those side effects. I want to target location, location, location. I want to find the right place that provides the maximum benefit with the least amount of side effects. And perhaps neuronal signals, local field potentials, during the actual placement of these will give us clues to that, and I think that's an important part. Additionally, there's technology now that allows us to steer the current. I've showed you 4 small electrodes that really create a spherical stimulation site now. Now the manufacturers are creating devices that allow us to more precisely steer current. And so if we're up against a signal, an abnormal signal in one direction, we can start pushing it in the other direction. And additionally, we're able to record these chronically. Combined drug stimulation therapy, is there a role for optogenetics, looking more at the single cell, the single synapses and neurotransmitters? I think there is evidence certainly that additional neurotransmitters are involved in Parkinson's disease, not only dopamine, but perhaps acetylcholine, norepinephrine, other neurotransmitters at various levels. And so understanding that is important, and combining optogenetics with DBS in animal models, but perhaps in humans, may help us identify better ways to treat people. There's opportunities for personalized therapy. Again, if we can determine neuronal signals that signify tremor versus bradykinesia versus rigidity, not everyone with Parkinson's disease is the same. We saw an example of a patient who has the rigid bradykinetic version without tremor. Is there an optimal stimulation parameter that I can provide to her as opposed to the patient who has a tremor predominant standpoint? Those are important questions, and certainly will have large effects on how we treat patients. Pattern stimulation, currently we're stimulating constantly. Is there a reset signal that we can send periodically that might save batteries, those types of things? And then, of course, dynamic disease equals dynamic therapy, creating closed-loop therapies, recording potentially beta oscillations or phase amplitude coupling or coupling of various beta to gamma frequencies might allow us to better treat these patients by constantly recording and allowing us to create an adaptive stimulation parameter, whether that be alterations in pulse width, signal, etc. And those technologies are obviously fascinating to me. I think you're probably familiar with those, but doing that at a local level within the subthalamic nucleus, within the GPI, but also perhaps thinking about these ECOG devices where we're measuring the motor cortex output, ultimately driving the signal and creating a feedback to the DBS device. So I think, that's all I have to say. A few special thanks for the colleagues that I work with on the clinical side, and also in some research endeavors here. And that's all I have to say, so thank you very much.
I think we have time for 1 or 2 questions.
That was great. So I think this audience might really appreciate some discussion about you have lots of knobs to turn once the device is implanted. I know a little bit about this through some exposure to clinical Parkinson's.
Yeah.
I'm curious your thoughts on sort of, you have too many knobs. Also, as I understand it, some of the knobs you turn change some parameters for DBS. The effects of that don't occur immediately, but could be a week later or something like that.
Yeah, so great.
It's a big problem.
Great question. I don't think we have too many knobs currently. I think with new devices coming out with current steering and those types of things, I think those are concerns that we have. But I think that the knobs that we have, voltage, pulse width, frequency, they all play a role. Frequency seems to be more important for tremor. Higher frequencies, we see a lot of improvement in tremor. Gait can be affected by pulse width, and obviously if we stimulate the voltage. So I think it's a very important component. The second part of that question was, what is the immediate effect versus the delayed effect? And certainly we see the tremor melt away just like that. We turn on the device, gone. The rigidity, the stiffness in the muscle, turn on the device, gone. Bradykinesia, the slowness moving, so we measure it like this, and if somebody's slower, that seems to respond in a more delayed fashion. It seems to be, at least in the maximal responses, in a more of a 40 minutes types of realm, minutes. Now, that's Parkinson's disease. Thinking about dystonia, so these are the abnormal postures that cause a lot of disabling features, dystonia is very challenging to program from a DBS perspective because the effects of stimulation are much delayed, often on the magnitude of weeks to months after we make adjustments. And so, what's causing that? Likely neuroplasticity. At what level? We don't fully understand that. And so that's a mechanistic component that's very important in thinking about these circuits. Did that help clarify some things and answer the questions?
Quick follow-up. Do you envision giving the patients an opportunity to tweak their own parameters, or do you think that just, as I understand, that sounds attractive to engineers, but maybe not so much to patients?
So we run into problems when we allow patients to tweak devices. Giving them an A option and a B option. They switch back and forth, and then just those delayed effects that we have no way of measuring those. Now, with wearable technologies, perhaps we'll be able to, collaborate and obtain more data and synthesize that data outside of the patient's subjective experience. Now, is that important? I don't know. My goal is to improve the quality of life of the patient, right? And so if they have less tremor and I see that on a Fitbit watch or another device, and that doesn't make their quality of life better, then it's not really serving the purpose of what I want to do clinically. But I think in the adaptive realm, those are some of the things we can do from a technology standpoint. Given the patient, the knobs and buttons, I think that's too complex. There's immediate effects, there's delayed effects. Animals want instant gratification, and sometimes at the cost for delayed gratification. I think as physicians, as clinicians, we're able to recognize that and program accordingly. Sure.
Do we have one more?
Is there any growing clinical consensus as to whether the viruses that are used to put the optogenetic proteins into the genome are mutagenic or not? I know there's at least one large human study using these viruses, but there's probably more. I'd love to get your thoughts.
Yeah, so the question, for those of you who couldn't hear it, essentially was, are the viruses used for optogenetics, is there mutagenesis potential from a clinical perspective? And I think, I don't know the answer to that, but I certainly have concern about that. And I think you're right. The one study that we've seen that in is certainly alarming. In Parkinson disease, I think about this in the context of stem cells, right? And so stem cells showed a lot of promise. We stuck some stem cells in the brain, and lo and behold, patients who we did that, never in the animal model, or rarely in the animal model, but in the humans, we started seeing tumors. We started seeing runaway symptoms that weren't uncontrollable because these stem cells did things that were unanticipated. And so I think certainly the same potential is there with viruses. And I think certainly for that reason, from a clinical perspective, absolutely starting in the animal models, the MPTP primates, the MPTP rats, OHDP, et cetera, provide an opportunity to study that a little bit more long term. And personally, I would have reservation proceeding with something like that today for that reason.
All right, Scott, thank you.
Great. Thank you.